Good morning and welcome to this edition of my YouTube channel, Pain Free Partha. You are now going to see something of 15 minutes of some basic information about prothrombin time. So, whenever we are going to talk anything about coagulation, we should know what are the coagulation factors like. So we know this is fibrinogen, prothrombin, calcium. Then factor 4 is probable phospholipid proaccelerin or labile factor. 6 is they call us no factor or accelerin or old name of factor 5A. 7 is stable factor or proconvertin, anti-hemophilic factor, Christmas factor, Stewart-Paraver factor. This is PTA, plasma thromboplastin antecedent. 12 is H1 factor and 13 is cross-links fibrin stabilizing factor. Now prothrombin, what it deals with? This is factor 2. So that is what we should be. Active form of prothrombin is thrombin. Okay. Active form of fibrinogen is fibrin. So from prothrombin to thrombin. Now we'll go to the next slide. Now basic, this is very basic. What I want to tell is extrinsic pathway and the intrinsic pathway. There is a tissue trauma. Here there is a contact with collagen. This is about calcium factor 7 becomes 10 to 10A. This 10 to 10A is a common pathway. Here it is basically 7. Here it is basically 8 and 9. So this goes on to form 2 to 2A in the presence of calcium. Where again prothrombin forms 2 to 2A, but there is no factor 7 here problem. So thrombin, then thrombin fibrinogen to fibrin, fibrin stabilizing factor becomes stabilized fibrin and clots. This is intrinsic pathway and this is prothrombin time measures the time taken by the citrated platelet poor plasma to form a clot in the presence of sufficient concentration of calcium and tissue thromboplastin. This is what is the definition. What does it do, prothrombin? What does it check? It checks the time taken by the citrated platelet poor plasma to form a clot in the presence of sufficient concentration of calcium and tissue thromboplastin. This is about all about an extrinsic pathway. Now, the prothrombin test was defined as a coagulation time of a mixture of platelet, tissue factor, and calcium. See here, quick prothrombin time, 1935, where he did in patients with obstructive jaundice. That is a coagulopathy in patients with obstructive jaundice. Then this fellow quick used the prothrombin time to find out this. Prothrombin time test extrinsic pathway, very important. Performed by adding mixture of thromboplastin to citrated plasma. Now, what is this ratio? Patient's prothrombin time. How much seconds does it take? This is the control prothrombin time. This is what the standard. We know that the prothrombin time is. This is the ratio. Now, what is the normal value? 11 to 14 seconds. The prothrombin time is around 12 seconds, 13 seconds, 14 seconds, something like that. What is INR? Then we call it as international normalized ratio. Now the problem is we are adding thromboplastins. These thromboplastins are extracts of brain, lung, placenta of animals. So this thromboplastin may vary in their quality to affect the prothrombin time. Now, if you company A gives thromboplastin, this may be changing. Prothrombin time may be 15 seconds. This company is giving the prothrombin time maybe 9 seconds. So that is what we don't want to know. They may result in the erratic control of. So that is why we call it as INR. Now what is prothrombin time? Prothrombin time is 12 seconds. Now we have a control. That is 12 by 10. That is not INR. This is a normal prothrombin ratio. Now what is INR is prothrombin time of the patient by PT of the reference into the power of international sensitivity index. The manufacturer will give sensitivity index of our thromboplastin is 1.2. That has to be to the power. Now prothrombin time of the patient, prothrombin time of the normal pooled sample or the control to the power of ISI. International, that is what is INR. Thromboplastin may vary. Each manufacturer will give ISI value. Now, if the manufacturer gives ISI value of 1, the sensitivity is the same. Now 12 seconds INR will become 1. If it is 2, then the batch is half sensitive and it will become to the power. So that is usually it is between 1 to 1.4. Now we take an example. Patient's prothrombin time is 16 seconds. Now the control is 12 seconds. Now the normal prothrombin ratio is 16 by 12, that is equal to 1.33. Now if the international sensitivity index given by the manufacturer is 2, then it is 1.33 into the square, that is 1.76. Understand? This is what is called the international normalized ratio. INR is different from prothrombin time. Prothrombin time is normal 12 seconds. Prothrombin time ratio is 12 by 12. Control value is 1. But if the 1 is to the power ISI index 2, then it becomes different, or half, it becomes different. So this 1.33 will become like this. So how much for the results time to come? Usually it may take 9 minutes. There are bedside things because some valve replacement patients can have their own home kits. They should know how to identify. They can get their home kits also in 5 to 7 minutes. Fundamentally, we should understand that all clotting tests should be done with plasma. But there is a difference between plasma and serum. Plasma in the, if you take out the clotting factors, then it is called serum. So what is the use of testing some coagulation test in serum? So we need to have plasma samples. Standard percutaneous phlebotomy is enough. Or otherwise, if you flush properly and remove this, and indwelling intravenous lines can also be taken, and a fresh blood sample has to be taken. It should not be half ringer lactate and half blood. Now you see all is the blue collection bottle. See here sodium citrate, coagulation studies, invert 2-3 times, invert 5 times. This is chemistry. This is for heparin chemistry. This is for hemoglobin, hematology, HbA1c, etc. This is for blood grouping. This is for glucose, sodium, potassium chloride, etc. This is for culture. This is what is the standard color coding of your collection tubes. This contains sodium citrate. Now, in this light blue top that contains sodium citrate, serves to chelate the calcium and prevents the activation. So these chelation can come. Tube filling must be within 90% of the full collection volume. For example, if you have a 5 ml tube, at least it should be 4 ml. Gently inverted, not much of shake. So this is what you should, at least 80% it should be there. At least 80% filling should be there. It is also prolonged in factor 7. It's also prolonged into 510. But not useful for factor 8 and 9. This is what is important. We are going for 2-7. That is why it is extrinsic pathway, not intrinsic pathway where 8 and 9. Hemophilic and Christmas factors are there. EDTA anticoagulation is used for blood counts, and what we have is sodium citrate because you need this sodium citrate for this. What is the importance? Why we need prothrombin time? Liver diseases, warfarin therapy, vitamin K deficiency. These are the 3 things. Liver diseases, because liver makes prothrombin. Warfarin therapy. Warfarin competitively inhibits with this VKORC1, an essential enzyme for activating the vitamin K. Vitamin K deficiency can be have some other diseases. Sepsis, especially any disease that causes DIC. So prolonged prothrombin time is a sign of consumptive coagulopathy and disturbances in host response mechanisms in sepsis. There is a consumptive coagulopathy in patients with sepsis. It consumes the coagulation factors. Sepsis, there is a coagulation disorder. It consumes the coagulation factors. So the patient gets an abnormal prothrombin. That is what is called consumptive coagulopathy. Do we need to correct INR or sepsis? That we need to understand. Factors also rise anabolic steroids, septron, propranolol, metrogyl, all fluoroquinolones, that means ciprofloxacin, levofloxacin, omeprazole, antiphospholipid. There are so many factors which we need to understand and by heart. Chronic alcohol, septron, propranolol, metrogyl, fluoroquinolones, INH, omeprazole, all these things may rise INR. Think of lab errors. So alcoholism with minimally deranged LFT, PT-INR may be normal or IN normal. But when what is important in liver diseases with alcoholism, where there is not much derangement of LFT and your prothrombin time may be normal, we do some insult during the operation. So post-operatively, we can see some sort of increased INR in patients with not very minimally deranged LFT, but your PT-INR is normal because we may cause some insult to the liver blood flow. Prothrombin time in APTTD during decreased is CPB by a median. See, prothrombin time may also increase in cardiopulmonary bypass surgeries. There is a coagulopathy of bypass surgery. That's a big topic. I will deal later. Pre-analytical problems. Why do we get abnormal INR when the patient is not having any disease? Insufficiently filled tube, unrecognized clot, delay of mixing like that. If you have a traumatic puncture, contamination with heparin, dilution with IV solution. That is what I told. If you are the IV is running and you are taking, half will be oral. Time between blood collection in if it is more than 6 hours. So, meaning of an elevated INR is substantially different. Yes, this is what we should understand. A warfarin treated patient's INR is increased is different. A sepsis patient INR is increased is different. The meaning is different. Why? In warfarin treated patients, an elevated INR suggests an uniform predictable reduction without an accompanying alteration of verbal. See, warfarin treated patients, if the INR is 2, yes, there is some problem. If the INR is 3, yes, the problem is more. But similar thing we cannot tell in sepsis. Clearly, the elevated INR will be quantitatively correlating with the degree of anticoagulation in warfarin. But in sepsis, there may be other factors like APTT. Factors which may decrease INR. You see, carbamazepine. Patients will be on carbamazepine. Patient will be on sucralfate. Patient, see, barbiturates. All these things may decrease INR. The patient may be on some barbituric acid as an anti-epileptic things. So, anti-epileptic things, drugs, barbiturates, and carbamazepine. All these things, yes, beware of INR. It may be decreased. If you have, as I am telling, storage time, high lipid content, hematocrit of more than 55, if the patient's hematocrit itself is 60%, there is some polycythemia, then your PTINR may be abnormal. If you never eat green vegetables, you don't have vitamin K stores. So if you eat a good amount of vegetables one day, you will experience a peak of vitamin K, which will destabilize your INR. I will tell again the clinical point in this. Now, you are having mitral valve replacement done. Okay, you are on warfarin. Now, if you take lot of green vegetables one day, then your INR will be decreased that day. Experience a peak of vitamin K. That doesn't mean you have to cut completely green leafy vegetables. You can take green leafy vegetables routinely and adjust your warfarin dose for an optimal INR for that case. So this is what is important. The surgeon, CTVS surgeons may say avoid green leafy vegetables. Suddenly, if you take green leafy vegetables that day, the INR will come down. This is what is the clinical significance of green leafy vegetables, vitamin K, and INR, especially in patients on warfarin with replacement valves. Clinical risk on INR. Yes, okay. INR is increased. Do everyone bleed? INR is increased to 1.8. Or is it simply legal? Do they have or does treating correcting INR fix PA? This is INR is one thing. Fix NR is a different thing. So the fixed prothrombin time is a new modified prothrombin time that is only affected by factor 2 and 10, is not affected by 7. So fixed normalized ratio fluctuates less than standard PTINR. So the fluctuation is less. If you take measurables, it will be more. If you take this thing, it will be less. All these things are little less if you do fixed prothrombin time rather than our routine PTINR. What usually we give, you have an INR to put 5 FFP. FFP contains substances, plasma proteins, electrolytes. Intrinsic INR of FFP is 1.6. That is what we should understand. INR of FFP itself is 1.6. Come on, if you have an 1.7 INR, if you give FFP, it may not come down. It may not come down. That is one factor that we should keep in mind. It may not come down to your normal. That is one problem. It may come down. It is sometimes the intrinsic INR is of FFP itself is 1.6. 3 or 4 INR, you give a FFP, then it will come down. If you have an INR of 1.6 only, and if you give FFP, it may not be useful. It may not be useful. Now you see how much FFP has to be given. If your INR is 6 and your target is how much, then you have to give 64 ml. Your 1.3 target INR, 1.7 target INR 3. Now your target INR is around 1.5. 6 INR is the previous thing. Then you may need to give 60 ml per kg of the dose. Your 2 ml means 30 ml. So your INR is 2 means you may need to give 30 ml. Okay, this is what is the basic thing. It may come from 30 to 60 for an initial INR of 2 to 6 because our target INR is 1.3. If our target INR is 1.7, then 6 to 1.7 needs only 36 ml. 2 to 1.6 only 7 ml per kg. This is what we should understand. The INR need to achieve hemostasis. Okay, my INR is 1.6. My hemostasis is fine. No, that is very questionable. There are a lot of studies which tells INR is not directly linked to bleeding risk. Now we go to heparin. Heparin typically prolongs the APTT because PT reagents contain hepatic binding proteins that block heparin effect. But high levels of high heparin can prolong both tests. Now that is what is important now. If the patient is on heparin, you may need to test APTT also. Prothrombin time may not be that helpful in a patient with heparin. Why? You have reagents that affect heparin. Direct therapeutic with SARS, dabigatran, argopetran, epiketran, so many drugs have come, especially after corona. Typically prolong both tests, but at low levels, dabigatran may not affect prothrombin time. Again, we may be knowing your orally acting anticoagulant drugs like dabigatran may not prolong at subtle doses. It may be prolonging at higher doses. PT, is the message clear? PTINR is not to be done as a routine. False values are common in patients where they don't have liver disease, no warfarin, and no sepsis, and no DIC. Nothing is there, but false value may be there. Because I have told so many causes, anti-epileptics, fluoroquinolones, so many causes I have told that may affect. Even green leafy vegetables. Vitamin K 10 milligram IVTDS, that is what I do, but usually we test after 2-3 days. It is not like FFP. FFP, if we give, immediately you can test from 3 to 2, it will come. But vitamin K, if you want to give 10 milligrams IVTDS, not our routine pediatric neonatal vitamin K, that contains 1 milligrams. You may need to give 10 milligrams of vitamin K IVTDS to give. FFP, yes, I have already told it starts from 60 ml to 30 ml per kg. What is your initial INR and what is your target INR? That depends upon this. Is there a relation between INR and bleeding? Yes, the relationship is questionable. An abnormal prothrombin time, see here, there are two things. The factor is not synthesized or there is a factor loss. These are the two things. When will the factor does decrease synthesis? Vitamin K deficiency, liver failure, because liver is producing prothrombin. Warfarin therapy, I know we not directly tested. Vitamin K gone with warfarin. Increased factor loss, that is the IC. So that is what is important here. Vitamin K deficiency, liver failure, warfarin, reduced factor synthesis. Increased factor loss is DIC. Thank you all.